Good afternoon. Can you hear me clearly through the mask? Okay. Good afternoon, everyone. I know it's after lunch, but we are going to try to keep you as informed as possible. Welcome to the Everyday Heroes Community Overdose Prevention and Response Strategies. My name is Elisa Sanchez. I am the Assistant Vice President for Transitional Housing at Samaritan Daytop Village. And I just wanted to share a little bit about what we have done with regards to the overdose response. As we know, fentanyl has taken our people by storm. And no matter how hard we try, we are still losing people to the disease of addiction. Samaritan Daytop Village started as a substance abuse treatment program. Many of you know us as a treatment provider. We still are. But in 1995, we opened our first shelter site, which was Four Bells Men's Shelter, which was opened as a substance abuse shelter. Imagine that. We opened as a direct result of the city prioritizing and privatizing shelters. And now in 2022, we have 28 shelter sites in our portfolio, 7 family sites, so we have about 865 families every night, and 21 adult single sites housing about 2,500 individuals every night. And so you can imagine what happens at those sites. As we know, it's not just at Four Bell, it happens at every one of our sites. At any given time, a client can overdose. And one of the responses that we took in collaboration with DHS was that all staff were trained in Narcan administration. On day one, when people come into orientation, they are trained and handed a Narcan kit. And all of our staff walk around with Narcan kits at the ready. In addition to that, we decided to go into a collaboration with Exponents, which was a real paradigm shift for Samaritan because we were abstinence in treatment and recovery. But as we move into a harm reduction model and understand that there's different treatment for different people, we had to change our mindset on how we were going to address this pandemic, epidemic of overdose. And so we've collaborated with Exponents, and we are now doing needle exchange, and we are actually giving clients fentanyl strips so they can test what they're using in a hope that we can save a life. In the beginning, we thought that perhaps we would be encouraging people to use, but it was just the opposite. We want people to know that if they're going to use, they should use in a safe way. So enough about us. I'd like to introduce you to the individuals that have put this presentation together for you, Ms. Kimberly Howard and Ms. Jamielee Polanco, my apologies, from the New York Department of Homeless and Mental Hygiene.
Well, thank you so much for that welcome, and great to hear all the great stuff that Samaritan Village is doing. Everyone can hear me, right? Okay. So my name is Kimberly, and my colleague here.
Hi, my name is Jamielee Polanco, and I am the Technical Assistant Specialist.
Yes, so I am the engagement specialist sitting in the Department of Health and Mental Hygiene, and today we're going to be presenting Everyday Heroes, Community Overdose Prevention Response Strategies. Okay, so just to give you a little background of where the unit sits in, we are the Overdose Education and Naloxone Distribution Unit, and I sit in the engagement team, and Jamielee sits in the technical assistance team, and this is a little bit of what other units in the Bureau does. Just to give you a little bit of goals for today, during today's presentation, we'll cover over a lot of content, but we want to begin with some of these goals. Walking today, we hope that our presentation will build your capacity and competence in preventing and responding to overdoses, providing tools and suggestions for proactive safety planning and overdose responses, addressing stigma, and develop a shared vision and language around overdose and drug use, develop a broader perspective of overdose crisis and what it looks like. So here's a brief agenda of what we'll cover in today's presentation. First, we'll provide a brief history of overdose crisis as well as present on New York City overdose mortality data. Then we will dive into some content regarding stigma and harm reduction strategies for overdose prevention. After that, we'll dive into some best practices and recommendations for you all as supportive housing providers and staff to ensure you feel prepared and equipped to prevent and respond to an on-site overdose. And lastly, we'll provide some recommendations for combating stigma within your agency, and we will provide an overview of relevant treatment and harm reduction resources. So I also want to say we want to allow some time at the end for questions. So if you can hold your questions to the end, that would be greatly appreciated. But first I want to ask a question. Who all have heard of the word Narcan before, know what the word Narcan is? How about naloxone? Okay, same word. And how about, is anyone familiar with the term the model harm reduction? Okay, perfect. Okay, thanks. So I want to go over some key terms for today that you'll see throughout the presentation. And one of them is opioids. Opioids are pain reliever, including opioids, heroin, and fentanyl. Fentanyl, a highly potent, fast-acting opioid. Naloxone, a safe medication that can reverse the effects of opioid and prevent fatal overdoses. And MOUD, which is medication for opioid use disorder. And we'll talk about a little bit about that towards the end of the presentation. I'm going to pass it over to Jamielee, who's going to talk a little bit about harm reduction.
Awesome, thank you. So just to get us started, I wanted to orientate our presentation around the model of harm reduction, and awesome that for the most part, everyone here knows what harm reduction is. And just to reiterate, harm reduction is a set of approaches that views harm reduction and substance use on a continuum of care in which it seeks to meet people where they are currently at. And I'm sure many of you already work in these settings. As you already know, harm reduction includes respect for people's individual life goals, as well as understanding that any positive change is a step towards well-being. Supportive housing is harm reduction. So supportive housing is a highly effective strategy that combines affordable housing with intensive coordinated services to help people struggling with either chronic physical or mental health issues to maintain stable housing and receive appropriate health care. So it's a double-edged sword, not sword, but it's a solution rather in two parts to provide decent affordable housing while maintaining a social network of coordinated care. This is done so particularly because it's the most appropriate and evidence-based way to address a lot of the social determinants of health that impacts individuals in their particular intersection in society. So now we're going to discuss a little bit about the history of opiate use throughout particularly throughout the decades in the United States. I do want to take a moment to again place drug use and harm reduction within a framework of public health and health outcomes. I want to highlight the role of particularly social determinants of health, such as individual factors, physical environment, education, food access, economic stability, and healthcare access. As we know that while we often look to these particular factors when we're discussing other adverse outcomes, we often overlook these particular elements of social health when we discuss drugs and drug use. And because we fail to consider these options and how these factors come together to impact both problems associated with drug use, but also the potential solutions that we can possibly brainstorm to these problems. So I thought to mention these to keep this as a foundation in mind. I would like to start with an overview of our opiate crisis, because our opiate crisis would not be here if it wasn't for the war on drugs. This particular graphic was coined by Richard Cohen in the 1980s, and it still rings true today about the ways in which prohibition of certain substances leads to an unregulated and unsafe production of these substances. This mirrors prohibition in the early 20th century of alcohol and the proliferation of moonshine. With that being said, we are currently seeing this prohibition of drug use being seen in the current opioid crisis, as we're seeing that fentanyl is currently being sneaked into the illicit drug market. And you will see later in the presentation how particularly fentanyl has increased and has changed the landscape of opiate overdose in the last 10 years. I would like to also discuss the role of trauma throughout history. Recent studies of addiction have found that the gateway drug to any other prolific drug use is trauma. Particularly, the regular act of dissociation in childhood leads to numbing with substances as an adult. And to engage in restorative justice of our communities, we must engage in trauma-informed care in order to develop connections. The legacy of opioid use in this country has stretched out decades, but to address this particular target population that we are trying to address in supportive housing, it's important to understand the ways in which growing up in certain environments impacts someone's ability to adjust. With that being said, the Bronx was burning in the late 70s, early 80s, so that little girl in that picture is probably a client you've probably seen at least one time or another. The city was plagued with pretty much the majority of the city of the South Bronx being in rubble, with landlords burning down their own buildings. Due to redlining practices in the 30s that determined that 5 to 10% of Latino and Black residents made a neighborhood detrimental, landlords found it to be more profitable to burn down their buildings than to rent to people of color. With that being said, over 250,000 people were displaced during that time. Additionally, we also know that statistics of veterans find that at least at one point there are high statistics that they will experience homelessness at one point of their lives. We also know that veterans of the Vietnam War in particular had increased exposure to opium due to the opium poppies in that section of the world. And lastly, in the top corner, you'll see that the Sackler family, who owns Purdue Pharma, they were not provided immunity from the opioid settlement, so they were found guilty of various counts of bribery. They bribed physicians, they were aware that they were pushing an addictive substance, and ultimately they created the crisis that we know today. The opioid crisis, and particularly this lawsuit, has revealed an inequity in healthcare practices, as private citizens with private insurance are often called chronic pain management patients, while individuals in public insurance are often inadequately weaned off the medication, if they're even offered the medication at all. Now we're going to discuss a little bit about New York City mortality data. As representatives of New York City Department of Mental Health and Hygiene, our presentation will focus on New York specific data. If you are from outside New York City, we highly suggest you research under your local jurisdiction for overdose data, which can be found at public health departments in either local or state offices. And while this data is critical for giving context and guiding our efforts, it can feel a little bit abstract. So I would also like to take a moment to acknowledge the lives that this data represents. In 2020, we received an increase of 565 overdose deaths in comparison to 2019. That is a total of 2,062 total unintentional deaths in New York City. The rate of overdose deaths also increased from 21.9 to 30.5 in New York City in 2020. And for the most part in 2020, probably due to the social isolation tactics due to COVID-19, we received anywhere from 3 to 5 hours that someone passed away from an opiate overdose. So this map is one of my favorite graphics, and it shows the rate of drug overdose deaths in neighborhood of residents in 2020. with the highest prevalence in 5 particular areas, 3 in the Bronx, 1 in Manhattan, and 1 in Staten Island. In particular, in 2020, the South Bronx experienced almost twice the number of overdose deaths in the entire city. Neighborhoods with rates of high poverty experience about 1/3 of all overdose deaths in the city. And as in prior years, the geographic patterns also reflect inequities in health, income, employment, education, and housing, which are all factors that we've previously mentioned as determinants of social health. And now I'm going to be passing it over to Kim regarding heroin and fentanyl.
Thanks, Jamielee, for walking us through that data. Okay, so now I'll take you through heroin and fentanyl involved in nearly all opioid overdose deaths in 2020. Also in 2020, nearly half of the overdose deaths in New York City involved cocaine or crack. So you'll see that 85% any opioids that can be mixed with these drugs. So this slide talks about non-pharmaceutical fentanyl in New York City drug supply. Non-pharmaceutical fentanyl is produced in illicit laboratories on a large scale and is being mixed into sometimes entirely replaced products prior to purchase. So fentanyl is a game changer. Overdose prevention is also important for people using cocaine or illicit pills or obtained from the street. Risks of overdose might be higher in cocaine users who are unaware they are consuming an opioid. So heroin, cocaine, and crack, counterfeit pills, ketamine, methamphetamines, and other drugs bought on the street or online can be cut or pressed prior to purchase. I just want to point out that there is no risk to overdoses from touching fentanyl. I believe that these slides will be shared with you, so you can see some of our research down at the bottom, our resources. I'll talk a little bit about stigma and harm reduction. So these are some of the words that we all have heard. Have anyone heard of these words before? Does anyone want to add to a word that they don't see up here that they've probably heard? You can popcorn, you can yell it out. Okay. These are some of the words that addict, substance abuser, junkie, clean. These are really stigmatizing language, right? And these language makes a person doesn't want to really open up to sort of communicate to one when they hear these terminologies. But however, we don't want to change what if a person says like I'm a junkie or I'm clean, I'm clean for 5 days, I'm an addict. We don't want to change the language that they have. We really kind of want to change that language when we're talking to providers, okay? Because the word clean. The word clean, the opposite of that is dirty. So it's basically calling someone dirty. And so the more center appropriate is currently abstaining from making changes or drug use. So some common risk factors is a change in tolerance, mixing drugs, using alone. So some risk reductions and strategies, and we've actually have handed some of those out, and you'll see them on some of the cheers. It's in the yellow card. And I'll point out one, especially it's really important in supportive housing, especially if you're in a single room, that there's a hotline called Never Use Alone. And this hotline allows folks to call and be able to have someone online, so if they feel like they haven't came back to the phone in a couple of minutes, they'll call 911, they know their location. It works really well, a lot of people use it, and it's definitely a good resource. These also would be provided, that hotline would be provided in the resources at the end. Okay, so next I'll pass it over to Jamielee, who would talk about overdose response and prevention.
Awesome, thank you very much. And I also want to mention our colleague Roxanne, who's standing in the back with our naloxone kits. This is a training video. We will be passing by this training video for our presentation currently. However, you'll be receiving these slides and resources at the end as well, and you'll have access to this video where our colleague Herbert will be providing the training. And now I'm going to be passing it over to Kim in regards to best practices for overdose response and supportive housing programs.
Sorry, we switched them.
Oh, sorry about that.
I'll talk about best practices in overdose response and housing programs. So this section is an overview of the best practices. It's sort of like a bulk of our presentation. Each supportive housing program is unique and has its different needs. Consider bringing this information back to your team and residents and collaboratively deciding what works best. These recommendations are intended to be broad, giving you tools needed to build your program toolbox for overdose prevention and response. Okay, so one of the critical best practices is Naloxone Access, right? To make sure that it is in your building. You know, some folks even does dispensing drives, but making sure that people knows where it is and know how to use it. Some of the other best practices is designated roles and responsibilities, formalizing response and emergency planning, harm reduction and treatment resources, and addressing stigma. And some of those we'll be breaking down. So first we will review some best practice for ensuring naloxone access on site. Several ways you can attain naloxone in New York City. One of them is through the pharmacy program. There are participating pharmacies where you do not need a prescription. They have what you call the standing order that is provided through the health department's commissioner. And this is sort of where a person can walk inside, request a naloxone kit, and receive it free of charge. We have provided those pharmacies with the list of resources at the end of the slide, which you'll be able to take it, and also via our website. You can go on there and you can see a list of participating pharmacies that have these free kits. There's another thing. Anyone has heard of the Opioid Overdose Prevention Program or is part of the New York State or New York City opioid? Okay, perfect. Okay, so that is another way. So our OOPPs provide free naloxones to laypersons, and we also have a list as well of those programs that are in New York City where a person can obtain a naloxone kit for free, as well as training and other services. So if you are considering to be a OOPP, there is, I'm going to advance to the next slide because that is where the information is at. You can copy this. You don't even have to copy, I'm sorry. These slides are provided to you at naloxone@nyc.gov. I just want to point out that we prioritize these kits. We have a lot of programs, a lot of people that are interested into having these kits. So unfortunately, it doesn't make sense for every program to become an OOPP. In efforts, we are very strategic about who we sort of give these kits to. And yeah, that is our inbox. So you'll have this at the end. Now I'll pass it over to Jamielee, who will talk about best practices and roles and responsibilities.
Awesome, thank you. So now we'll be discussing a few recommendations designed for roles and responsibilities in supportive housing on staff sites. While we recognize that not all supportive housing programs are organized in this fashion, most of these roles and responsibilities can be adopted. So recommendations for all staff is training, 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 and more training. So it could be annual naloxone training in addition to exposure to naloxone training at new employee orientation, in addition to CPR training and anti-stigma training. It's always helpful just to provide your staff members a general understanding of how to have these conversations or how to interact with folks who may be using substances in their presence or, just generally speaking in the community. Stigma and harm reduction is also critical just in regards to overdose prevention planning and emergency preparedness. And we recommend that whatever emergency protocols that are already in place, that staff and residents are included and that they are able to provide feedback, as it's essential for them to feel confident and supported in adhering to emergency response protocols. Recommendations for program leadership is ensuring a Naloxone access that can be either through a budget, becoming an OOPP, or leveraging community resources, just like other organizations. As leaders of supportive housing programs, we really encourage you guys to keep these ideas in mind to protect your community. Additionally, it's essential for program managers to engage in providing naloxone in communal settings. So that's providing a box, as well as ensuring after everyone has been trained that they know where it is and that it's easily accessible. That means that they should not have to ask for a staff member to receive a kit once trained. With that being said, I also want program leaders to determine in consideration to their current emergency protocol how overdose response fits in, and consider reflecting on today's presentation with fellow staff. Again, requesting feedback from staff and residents, but also engaging the building or management company, as well as third-party security and maintenance companies, as well as those particular employees will have different responsibilities, and it's essential for program leaders to engage these particular stakeholders to ensure that the emergency response is smooth. And if you're not sure how necessary these plans are for your residents, it would be really helpful if you were able to engage your intake managers and case managers, which I will speak about very briefly. And as you review and adjust your emergency response protocols to incorporate explicit plans for opiate overdose response, it's important to also consider the roles and responsibility of program staff and residents in these plans to ensure regular training and support, as well as for them to understand their full responsibilities. Now we're going to discuss recommendations for resident-facing staff, and here is probably the bulk of a lot of understanding and assessing the population, particularly intake staff. Upon new resident intake, it would be really essential for folks to have access and exposure to naloxone, even if they have not personally told you that they use substances. It's important just to have this information easily and readily available. Case managers and clinical providers also provide a very unique role in supportive housing structures. So we do also recommend, in addition to one-on-one sessions, to also do group sessions and incorporate it in other routine engagements, just to make it easier and honestly just kind of cohesive. It should be a general conversation that you would have as if you were talking about the weather. In addition, offering overdose prevention and naloxone training on a regular basis to staff and all residents is helpful, but particularly as distributors, if you are deciding to be an OOPP, it would be incredibly helpful to have these particular staff members distributing on your behalf. We also recommend that case managers and providers build a relationship with local providers so that there can be a warm handoff in the event that their clients need additional wraparound services that your program cannot provide. And with that being said, it's incredibly important to discuss whether or not wellness checks is necessary for your particular program and the role of wellness checks, particularly for high-risk clients. The role of sign-in books or key fobs to understand the ingress and egress of your program. And again, I understand that not all supportive housing programs would be able to have access to this. And we obviously encourage stigma-free and harm reduction conversations, both with your clients, but also with your staff members on a regular basis. We acknowledge that case managers and providers should be providing aftercare and follow-up after an opiate overdose. So a case manager or a clinical provider should be attending the hospital in the event that the client is in the hospital for 72 hours. Should be asking for a toxicology screening, as often clients do not know if they have taken something. So I have had a client where I was with them, they went outside, grabbed a drink from somebody, thought it was soda, it was not soda, and they overdosed 5 minutes later. So it's really essential and important that even if the client does not know, that you still request this information. And once this resident returns home, it would be very pertinent for the case manager to engage in safety planning or revising existing safety plans. Overdoses can be traumatic and triggering experiences for not only staff but residences, so it's incredibly important to engage in house meetings to just ensure that the rest of the staff and residents have proactive and safe support during this time, as well as encourage residents for feedback for future emergency responses. And in general, we encourage resident-facing staff to use the community as a guide in developing an emergency response, and as well as engaging in anonymous surveys or suggestion box in the event of any other feedback that is necessary. Recommendations for security and maintenance staff. So these folks are particularly unique because they may or may not be members of your organization and may be hired through a third party, which may create additional obstacles in developing your plan. So with that being said, the primary step is to engage these staff members and understand their limitations, their roles, and their responsibilities. And particularly if you can try to get in contact with their management company, it would be incredibly helpful for you guys to work together as stakeholders to develop a plan together. If, for whatever reason, some staff are prohibited from carrying naloxone on their person, it is essential to have, again, communal access readily available and to have other staff members be able to carry their naloxone on their person. If, for whatever reason, there is hesitancy, that can generally be addressed through anti-stigma training as well as naloxone training. So just as you would any other employee, you would probably have to engage in this type of orientation as well. And as we've mentioned before, wellness checks are incredibly helpful for high-risk clients. So particularly engaging the security and maintenance staff for probably like signs or factors would be incredibly helpful. Maintenance in particular should receive training on how to dispose of particular paraphernalia and items, and they often are very helpful in indicating the event of an overdose on site. Recommendations for residents. So peers play an incredible role in keeping their communities safe. It's important and maybe even necessary to identify 1 or 2 residents that are friendly with both staff and other residents, and who would be willing to engage in opiate response and training on opiate overdose response, not opiate response, and as well as making sure that in the event of an overdose on site that they'd be the one to respond. Likely you would have to demarc this individual's door, as well as provide a general schedule, and we highly suggest compensating this individual for their time. Additionally, to ensure success of such a program, we would have to also engage in regular overdose response training, as well as providing Good Samaritan content, as it's really important to understand the limitations some individuals have to calling 911 to their home, and ensure that there's proper signage around communal kit boxes. So even in the event of a previous training, even in the event that they do not read the pamphlet inside the kit, and even in the event that they have forgotten the various trainings that you've provided, they can still read the instructions on the board. So now we'll be discussing best practices and how to formalize emergency response plans. So it's really important to standardize who on site is in charge of training and who on site is in charge of administering naloxone on a general basis. So for example, if in the event there is an overdose on site that is non-fatal and the client needs to go to the hospital, it is the program director's responsibility to speak to NYPD. No client should be speaking to NYPD due to their particular vulnerability. So with that being said, delineating roles and expectations even in regards to CPR, AED, and other forms of emergency response is also essential to providing both support and clear understanding of what's supposed to be happening, and as well as providing and requiring an annual training for all staff. We'll also be discussing in a few other slides, or actually in the next slide, categories of levels of inebriation and how to properly respond. So identifying and responding to inebriated clients is really essential, because just because someone's inebriated doesn't mean we call 911 or escalate the situation. In the event that there's any question, we highly suggest speaking to the program director, and during nights and weekends, speak to the shift supervisor. Again, it's incredibly important for the program manager to be responsible to speak to NYPD in the event that they show up on site, and to provide general roles and responsibilities, because overdoses are traumatic and triggering. So providing best practices will be a safe manner for both staff and clients. So this is the categories of inebriation. A client in green appears to be inebriated but can listen and understand their safety plan. It is likely that they would have to stay in the lobby for a few minutes for supervision, but should be able to go upstairs. And upon going upstairs, staff can determine whether or not to do a wellness check. A client in the yellow may appear uncoordinated, but otherwise are able to listen and respond to staff and abide to their safety plan. In the event that they are able to do so, they should be in the lobby for at least 30 minutes until staff can determine whether or not it's safe for them to go upstairs. And upon that, staff may determine to make a nightly visit or two during later that evening. A client in red cannot sit or stand without staff assistance, cannot listen or adhere to their safety plan, is threatening or belligerent. If belligerent, you are to call 911 with an emotionally disturbed person delegation so that NYPD and EMS can report on the scene appropriately. And if non-responsive, you are to call 911 and respond to the overdose. I also want to take a time to discuss the Good Samaritan Law in detail. Out of concern of individuals' reluctance to call 911, legislation was passed so that individuals would be encouraged to call for help. While it's not perfect, it does provide protections for up to 8 ounces of substances or paraphernalia that is found on site. However, the law does not protect against immigration status, child welfare charges, or other probation or parole violations. Overdose response planning still needs to occur despite this. So, and despite the protections that may be in place, in real life we know that people may or may not still feel comfortable calling 911. So we have to take into account people's personal role and their ability and capacity to do so. And there may be other reasons why they may not want to call 911, as people with lived experiences of using substances may have reversed an overdose in their minds previously and may have not needed to call 911 or seek medical attention. However, there have been times where response can be traumatic either through the medical system or interaction with the police, fear of personal safety, again, issues in regards to legal matters. And as we know, NYPD often investigates overdoses, so there will be the risk of follow-up in the event that they do call. So now I'm going to be handing it off to Kim regarding harm reduction treatment options.
Thanks, Jamielee. So what does treatment look like? Not always abstinence is the ultimate goal. As we covered earlier, harm reduction is a set of approaches that views substance use as a continuum and seeks to meet people where they are. Many of you already work in the harm reduction framework and harm reduction settings, particularly as a supportive housing provider. But before we start talking about options, let's discuss some goals for treatment. There is a common misperception that abstinence, like I said, is always the goal. And some of the other examples include in other measures of success are reducing and managing substance use, right? Important overall health, preventing fatal overdoses, right? So any prevention of someone expiring is a success, could be measured as a success. Improve social networking and support, meeting goals of employment, family, or environment and community. Medication for opioid use disorder, which we'll talk about a little bit about that now, as a part of a harm reduction continuum of care. Every individual has a different goal related to their substance, and these goals often change over time. Thinking about this also in terms of harm reduction, some approaches goals of any treatment are to stay alive, to stay healthy, and to work towards one's own goals, recognizing that everyone's path is different and individualized. This is the terminology. Some may be familiar with the term MAT. Now we have sort of updated language, which is one of the words we said from earlier, which is MOUD, medication for opioid use disorder. MAT refers to medication for assistant treatment, which is a term mainly can be seen as like assisting versus MOUD. It's now a preferred term, even though folks still use the word MAT. It fits more in line with the accurate description of medication through MAT is currently used, and it's a recognized term. I think I advanced too much. Let me go back. Okay, sorry. Okay. Now we'll talk about some of the different treatment options. Methadone, buprenorphine, and naloxone. Methadone has a large body of evidence supporting it's sort of the gold standard of treatment. It's the longest treatment that's been around. Methadone is also a medication that prevents withdrawals and reduce cravings, and it is its maintenance use prevent opioid overdose risk. Unlike buprenorphine, individuals do not need to be in withdrawal to start the methadone. Methadone is also a medication that can be used to help treat chronic pain. A lot of people don't know that necessarily. Methadone is also available through a licensed opioid treatment programs, which folks in this room has those OTP licenses. The structure can be useful for individuals benefiting from structure routine. So I have to get up every day. I'm used to getting up every day to get my dose of methadone, and that that sort of getting into that routine works well. I'll dive into buprenorphine has some similarities to methadone, but also some key differences. Like methadone, buprenorphine prevents opiate withdrawals and reduces cravings and provides some protection against overdose risk. Buprenorphine can also be used to treat chronic pain as well. Unlike methadone, there's a built-in ceiling effect for buprenorphine that reduces the risk of misuse, meaning large doses do not generally increase the effect of medication. Unlike methadone, buprenorphine is available in primary care settings, emergency departments, and telemedicine, which we know have really scaled due to COVID. There are a few available forms of buprenorphine, including a daily tablet, a daily form. Usually this is and a monthly injection. One limitation to buprenorphine is that individuals need to be in mild withdrawal to start, and if they're not, the medication can have uncomfortable withdrawal effect on a person. And lastly, naloxone. Naloxone is another medication for opioid use disorder. This is commonly used as an alternative when the opioid, like buprenorphine and methadone, is not an option, or when participant has strong desire to avoid opioids. Naloxone is available as a long-acting injection every 28 days or less, and can be accessed in primary care settings. It does not require no opioid use for 7 to 10 days. So sometimes it's challenging for folks, to have not used within 7 to 10 days. Another thing too about naltrexone, it's really important that you want to remind a person that they've gotten a shot on day 28, that they need to sort of get that shot on that end of that cycle. So that could be challenging for people for various reasons, as we can come up with. And that sort of brings us to the 3 different, sorry, I'm advancing too much, right? So some of the key takeaways is that you want to educate tenants on all of their options available to them, right? Individuals on MOUD are still considered in recovery, so telling a client that they are not clean or sober, some of those words that we've seen before, and that's those words that, those stigmatizing language that's thrown out there, when talking about MOUD prevents clients from seeking and staying in treatment. And this is true for, as me and Jamielee have both, prior to working in city government, have worked with supportive housing, have worked with programs that provide supportive housing. So ways to help residents access MOUD and treatment. You want to help ensure clients have active insurance. So this is something that you do prior to sort of setting up those appointments or figuring it out with them. You want to remind them of upcoming appointments if possible. You want to facilitate exchange of medical information, so some of those HIPAA forms that we all know very well. We want to provide information on availability and other options. We want to identify medication-friendly mutual support groups for clients who participate in MOUD. And abstinence and detox. Again, this may not be an option, the ending goal, but it is an option, and some tenants do seek this option. So if that is the case, OASIS has a 24-hour hotline. It's called Hope Line. And the information is provided there, where you can do an OASIS program provider search to see if a person has available bed, programs have available bed, or what type of services that they may have. Social networks and connections. This is really important, and one of the things I would highlight here is there are providers can provide groups. A lot of times they do with incentives. This is a great way of tenants sort of having that peer, something what Jamielee was talking about a little earlier, that one-on-one connection that really brings folks together. Sometimes they find out they have a likeliness and substance use that brings them together. There's community walks. I know New York City Department of Parks has a lot of things that they do and that they highlight. One can look that up and put some signage around their agency and corral a bunch of folks. Turkey ham drives during the holidays, community gardens, community spaces, those sort of things. And now I'm going to pass it off to Jamielee to talk about tips for addressing stigma in your organization.
Thank you, awesome. So I hope you are able to walk away from today's presentations with a few more tools in your toolbox in regards to addressing opiate overdose at your communities. However, in order to use these tools, it's essential to be self-reflective and work to address stigma in your organization. You can do so by engaging in creating a culture of care, and actually caring about your clients. And I know it sounds kind of like redundant. What do you mean? Like, of course, but it's genuinely having the clients feel as if you care. So that may also include, again, gardening and community walks, but also noticing that at the end of the month, your client doesn't have any more food stamps, and providing cooking classes, really addressing a lot of the smaller needs that maybe go unchecked and unnoticed is really essential. Increasing access to information and resources, and identifying your clients' motivations and your staff motivations for developing a safety plan in regards to their substance use, or even in regards to addressing opiate use within their community. Again, leveraging holidays and birthdays and homework help is the idea of this should be a general conversation, easy to have. Previously, before working for the city, I used to engage in as a OPP manager, and I would go to different sites and do art therapy. It has nothing to do with opiate overdose, but it's an opportunity to have those type of conversation, and also to distract people from maybe other challenging moments that they're having in their life. And I just also want to slide over these resources. You will have access to all of this, but we'll just discuss it really briefly. In the event that you need readily accessible naloxone and do not have access to an OPP, you can just either email this link or actually go to Next Distro, that's a website, and request a naloxone kit. Also, really quickly, in the event that you would like to know if there's an OPP in your community, there is also a list on our website as well. Resources in regarding to harm reduction, so here is the Never Use Alone hotline, as well as local syringe programs. And some resources on how to find treatment, and I would just like to highlight really quickly the OASIS provider and program search, as well as the SAMHSA buprenorphine treatment practitioner locator. And I just want to take some time to reflection now that we have reached the end of our presentation. We're just circling back again. Everyday Heroes is essential to develop a mission statement for your supportive housing program and community to reflect on your vision and values as an organization that is essential to understanding your motivation and capacity for addressing opiate overdose. So again, previously to working for the city, I worked for a community-based organization called BronxWorks. Their organization motto is to teach, shelter, feed, and support. So their OPP program, I created the motto of the OPP's mission is to teach and support Bronx residents in Naloxone Access and opiate overdose response that leverages community and social networks. So it should be something that's within your wheelhouse, something that you guys already feel and believe that will make it much easier for you to engage in readily response. And thank you very much. Thank you and happy Thursday. And if you guys have any questions, please feel free to come up. Thank you.
I just want to mention also too, oh wow, now I feel like I can hear myself great. Always at the end, right? Our Roxanne, in the back, who will be dispensing kits, and we want to also thank Roxanne for helping us with this presentation. And it's about a 5-minute training, but if folks want a Narcan kit free in the back, Roxanne is there, and I think we'll be back there later on. But again, we're here to take questions. So, thanks. Yes, you can ask a question.
If you need to ask a question, go to the microphone in the middle.
It's kind of hard for us to hear, sorry.
Sorry, I was trying to avoid standing up. My voice travels.
I'm sorry, everyone. I'm just trying to hear. I know we're all leaving. I just want to hear this person's question.
I do have a question. First of all, thank you for the presentation. What I'm noticing, there's a lot of focus on opioid use, and what we don't hear of too much is those individuals who are engaging in methamphetamine, crystal meth. And if you can point us to if you have any resources that can point us in a direction, because there's a lot of talks about opiate use and how to minimize folks overdosing. But when it comes to crystal meth, I find that there are very limited resources online, and I work at a safe haven, and we have a handful of clients who do engage in methamphetamine use, and a lot of the conversations that our case managers and clinical coordinators are having with them are really stemming from opiate prevention, overdose prevention.
So I agree with you, right? And I think that those conversations are happening now, right? And there's, Gay Men's Health Crisis have their program. There's some other programs around that are coming up. And I agree with you. I wish that I had an answer for you, but I know personally that those conversations are happening now, happening at the health department on the city and the state level, and as well as in private partners.
And likely because the reason why a lot of practitioners offer opiate response in regards to methamphetamines is because oftentimes these substances are made in similar labs. So it's just mostly in regards to cross-contamination.
Thank you.
Yes.
Hi. Can you talk to us a little bit about the implants? This new about implant that lasting for 6 months. Do you know anything about that?
I'm sorry.
So, yeah, that they're being used, implanted, and the effect, and I'm not sure which category it falls under, but that it blocks then the effects it helps for 6 months. Then you would have to go back and be re-implanted as opposed to the injection or the pill. You know anything about that initiative?
So no,
I was excited about that one.
Oh, okay. I'll pass it over to Jamielee.
I do know that's like a new medication that's being offered. However, currently there isn't enough funding, and oftentimes that is through private insurance. So largely it's private folks who have access to that. As of right now, we can only recommend methadone as the gold standard and buprenorphine and naloxone as like the subsequent standard for now.
Okay, thank you. Here you go.
I think there was a question in the front.
Thank you so much. As a housing provider, we're struggling with bringing in harm reduction resources into sites, particularly fentanyl test strips, Narcan training for tenants, doing it as a larger collective. Has the department thought about doing more outreach to housing providers and providing those resources directly rather than going through an OOPP?
Right. So I would say yes, and one of them is this here, right? To sort of give language to, and I think that's something that's trickling down, unfortunately. But I mean, I don't know if that answers your question.
Or like, for example, the fentanyl test strips. I've reached out to several harm reduction providers. Not a lot of response right now on that availability. So where do we get those resources? How can the department bring them into housing providers?
I know recently they just had released the RFP for fentanyl test strips, and so they had a window open. They had sort of some programs. I do believe that the health department probably have received I should refrain from that. I believe that there probably would be an additional RFPs that might come out. So you probably can see that to probably gain access. But again, these fentanyl test strips, a lot of providers do, want them and use them. So the health department is just trying to figure that out.
Also, if you're looking for additional resources, our training department is always happy to go to your site and engage in that type of work as well.
Hello. So I have two questions. The first one is we didn't talk much about it, but is there coming out or any new ways to test for K2 for a lot of the members? Because I work with a lot of members that are on K2 and then end up being hospitalized, going into detox and things like that a lot of times off of K2. So is there any ways or anything that's coming out to test for that is affordable to programs and things like that?
And then you had a second question?
Oh, so I was going to go.
Oh.
So the second question then is, a lot of my members also are formerly incarcerated. So is this type of training and information being passed down to docs while they're incarcerated and helping them address these issues prior to these men and women coming back out into the community? Because a lot of my members within the first 24 hours are in the hospital for substance use.
Right. So to answer your first question, we sit in the Drug Bureau, so, but our focus is mainly on opiate overdoses. So I couldn't really speak towards K2 because we work in the Naloxone distribution unit, so that's our focus. And then for your second question would be, yes, Health and Hospitals oversees sort of the contract with the Department of Corrections, even though we do have some input and we do have some say. But yes, there are RFPs that are prioritized to folks with justice involvement that our unit makes sure that we have funding available for folks who is coming out of incarceration or has a higher prevalence of returning, coming in and out because of tolerance as well. So yes, your answer is yes.
Also, we're engaging in a partnership with the Department of Probation to also provide naloxone kits to their clients as well.
Hi, I just had a question. So at our agency, we started a more robust OPP program around January and February. Part of that initiative is getting not only staff trained, but all of our residents trained. In doing that, we understand that if our residents are going to be responding to overdoses, it could be re-traumatizing, triggering. Do you have any resources for debriefing residents or active users who are responding to overdoses?
Definitely, if you can send out an email to naloxone.nyc.gov, I will definitely be able to provide you additional technical assistance in regards to that. But just very quickly, providing house meetings might be the best way to engage it just head on, because that way clients also feel that you actually care about them in the event that they were to go through an overdose. Oftentimes, if it's fatal, unfortunately, the ability to have time and obituary, time for other residents to reflect on that particular individual, and just again, like in the event that it's not fatal and the individual is able to come back to the community, welcoming that person back to the community and having very clear conversations about what is happening. I think oftentimes just because it's an emergency and maybe it makes us feel uneasy, we try to avoid having these really tough conversations. But it's really essential because it also makes people feel more willing to ask for help. And yes, it is re-traumatizing, but I have found in working with individuals that in the event that they do reverse an overdose, they feel really empowered because it allows them to kind of redeem themselves in their minds of an overdose that they had not been able to address previously.
Thank you.
No problem. Is there any other questions? Okay, awesome. If there aren't any other questions, thank you guys again so much. We will definitely be sharing these resources to all of you.